So we do want to continue with our lecture and talk a little bit more about falls. So while falls in the community are pretty prevalent, falls in the nursing home are even more so. We know that falls in the community lead to 40% of nursing home admissions every year, and that residents in long term care or nursing homes are more likely to have injuries after a fall than those in the community. That's primarily because we have different carpeting, different surfaces, and there's other things that might not be in the way. Falls often result in fear of falling, loss of independence, and a lower quality of life. It's not a normal consequence of aging. A fall does not need to occur. And approximately 20% of hospitalized patients will fall. And we have a lot of different fall prevention programs that are being conducted across the United States and other areas today to help reduce falls and to also help get people to be more aware of their potential for falling. So we've talked about some risk factors for falls. Let's go through those again just as a review. If a person has a prior history of a fall, if they have difficulties with walking and balance, lower body weakness, vision or hearing problems, if they have postural hypotension, so their blood pressure drops when they move from lying to sitting, sitting to standing, if they have any urinary frequency, hesitancy, urgency, or incontinence, because they're in a rush to get to the bathroom. We have a lot of medications that cause risk factors for falls, and we'll talk more about specific medications when we get to the geropharmacology unit. We've already discussed foot pain and improper footwear. We've discussed some hazards in the home, and this is a good example of a throw rug hazard. And then confusion or impaired judgment can be a big impact on falls. We can also have animals that can cause falls, but usually they aren't the ones that do that unless it's some type of an animal who really pulls on the leash and causes a fall when the person's going outside. But a lot of times the animals are not the cause of falls. And we've been able to show that to a lot of family members at Tiger Place, where the animal was definitely not the problem in a particular apartment. Consequences of falls, as I mentioned, they're the leading cause of injury. We have two big areas that are primarily affected by falls: traumatic brain injury and hip fractures. So traumatic brain injury is that leading cause. Falls are the leading cause of traumatic brain injury in older adults. Sometimes, and perhaps even more often, this diagnosis is missed and believed to be a mild head injury. And then because of structural changes in the brain, some shrinkage and some changes that happen due to aging, a expanding subdural hematoma with delayed onset of symptoms gets missed quite often. It's not going to get picked up initially. The whole point of a subdural hematoma is that it doesn't get picked up until much later. Hip fractures, 95% of hip fractures are caused by falls. About half of these will not recover back to their pre-fall ambulation ability, and that's really too bad. A lot of times a hip fracture, especially in an older adult over 85, is such a life-altering occurrence that their death occurs shortly thereafter. I have this algorithm. It's also under modules, so you can look at it there too, because I realize this is not a very clean copy. But basically, the algorithm takes you through, okay, are they at high risk or not? If you say no, then you put them at low risk and you let them know. So over here it talks about educating the patient, making sure they have enough vitamin D and calcium, and refer to strength training. If we say yes to some of these screening questions and we move on to the next section where we do some assessments, evaluate gait, strength, and balance. If there are no problems, then they get put in low risk again. If there are some problems, then they may be in the moderate risk, or we might end up putting them in higher risk. And so it just kind of runs you through, where's this person at? At Tiger Place, we have computer programs that can do that automatically, but we also do this face-to-face every 6 months as well on every single resident. There's also a checklist under modules for you. Both of these come from the STEADY intervention, which is on the CDC website and is a evidence-based practice intervention. The checklist is kind of a quick and dirty way. Yes, no, about what's going on with the resident, and then it can help you kind of keep track of what's been happening and how to move forward. Now, I have put a link to the STEADY, a STEADY training, online training program. If you are interested in that, it is optional, but please complete it if you're interested. If you do complete it, hey, shoot me an email. Let me know how it is. I may use it for an assignment in future classes. So the STEADY is just one of many fall prevention programs that are available. I wanted to give you an example of one, and then if you come across another, just realize that there's more than one that's available out there. And we want to use as many resources as possible to help prevent injury and consequences to our older adults. We've talked a little bit about the Timed Get Up and Go test, and we'll talk about it in more detail here. So Timed Get Up and Go is a test that we can do that's pretty quick, where we can get a fairly good assessment of fall risk. The interesting thing, and I included an article on this as well, but the Timed Get Up and Go test actually can measure much more than just fall risk, because the person has to know, they need to understand your directions, they need to follow your directions, they need to do a whole lot of cognitive processing in order to do this test. But for fall prevention, what we do is they have them sit in a chair with armrests, put their feet flat on the floor. They need to stand up. They can use their arms if they'd like. Walk forward 3 meters. That's about 10 feet. Have a mark on the floor so they know where that's at. They can do that at their own normal pace. And then they are to turn around, walk back to the chair at their normal pace, and sit down again. From the point they stand up to the time they sit down again, that's what we measure in seconds, and if their time is greater than 12 seconds, they're at an increased risk for falls. So this is another little more information with the citation of the article I mentioned. It is a very simple test, and it certainly measures balance and mobility, but it's also measuring some of these other cognitive processing mechanisms. So they have to accelerate and move their body forward. They have to push off and stabilize their trunk, and they have to appropriately initiate movement. The Timed Get Up and Go also measures cognitive function and challenges, so they have some planning, orientation of space and self they have to deal with, and it can be taxing to cognitive reserves. It's a true measure of executive function. And those individuals with times greater than 12 seconds has been associated with institutionalization, so long-term care facilities, impaired functioning, impaired mobility, and even death because of falls related injuries. It's a pretty sensitive indicator of early changes in functional status. The other things we want to look at as far as falls go are medications, and if our patients are on Some of these medications that are listed in this chart, if we get a score of 6 or greater, we want to refer to a pharmacist so that we can evaluate and see if there's any medications that we can pull. So the medications with the highest point value are analgesics, especially opioid analgesics, antipsychotics, anticonvulsants, and benzodiazepines. And there's reasons over here on the right for why they're a problem for fall risk. Each medication would get a 2 if they're on an antihypertensive, a cardiac drug, an antiarrhythmic, or an antidepressant, and they'd get a score of 1 if they're on a diuretic. Again, any score greater than equal to 6, they should have a pharmacist evaluate. And then if they're in the hospital and we saw them hit their head or saw them fall, we want to do an assessment. It's going to involve 2 things. First, did they hit their head or didn't they? And you can't just take their opinion or their answer to that question. You need to palpate their scalp, check for bleeding and bumps. And if they have any pain when you palpate their scalp, they may have struck their head and not remember. We've actually had a resident at Tiger Place who fell, didn't recall falling, actually broke the frame of the door with his head when he fell. And in this case, he didn't realize he'd fallen. He got up and went to shave and finish getting ready. He had blood running down his face, didn't think that was a problem, and had absolutely no recollection. So it's real important with older adults that you do a good assessment as well. So, of course, if they didn't hit their head or if they hit their head, the first things, if you find them on the floor, is to assess airway, breathing, and circulation. Check vital signs. You can palpate the cervical spine for an injury. If the person has any pain when you press on any of the cervical spines, bones or bony prominences, then don't move them, don't move their head, and we need to get a cervical collar. Clean and dress any wounds, and provide any analgesia as needed, non-opioid if possible. Inform the provider so they are aware, and family members, and then arrange for any further testing, and then observe every 4 hours for 24 hours. You're going to do neuro checks and vital signs during that time, and then review the care plan and add any fall prevention strategies that we can. If they did hit their head, we're going to do the exact same things as above, but we're going to add the Glasgow Coma Scale to assess a more specific neurological status, and also to assess for headache and nausea and vomiting. When we have someone who has struck their head, we're going to do vital signs and neuro checks at least hourly for 4 hours, and then every 4 hours for 24 hours. Fall risk is definitely higher in nursing homes because the residents have a greater level of frailty, greater age levels, more chronic conditions. They typically all have more difficulty walking and or taking care of themselves, and often have memory problems. So for fall prevention activities, we want to be able to identify high-risk residents. We want to do fall prevention with every single employee in the building. So from dietary to housekeeping to maintenance, if anyone identifies someone who they're worried about or are concerned that they might be at risk for falls, they should feel very free to come and talk to the nursing staff about that. We want to monitor newly admitted residents, closely monitor residents during acute illnesses, especially if they're having delirium, monitor medications, and work with physicians to deprescribe medications that promote high fall risk, and quickly eliminate any environmental hazards. Also, for a witness post-fall assessment, we're going to monitor that resident for 72 hours, check orthostatics, finger stick glucose, pain, swelling, and changes in cognition. We're going to notify people right away, investigate fall circumstances, complete that fall risk assessment, and monitor staff compliance and resident response. Just a quick overview of subdural hematomas. Remember that typically our resident will have an immediate loss of consciousness, but we don't always know that, especially if it was an unwitnessed fall. So anytime you have someone where if they lost consciousness and then woke up and seemed like they were fine, or if you're not quite sure and they seem fine, if they have a rapid decline in level of consciousness later, from hours to days later, they need to head to the ER stat for a CT scan, unless they are DNR or in a palliative care situation. Appropriate transfers to the emergency room. Certainly uncontrolled bleeding or lacerations that require stitches, suspected fracture, deformity of limbs, or acute change in cognitive or neurological status. If they're on anticoagulants and they've struck their head, then they need to see the provider, just to make sure there isn't an active head bleed going on. It gets a little bit tough if our patient's DNR. Then typically what needs to happen is, for the facility, the nursing home should have a form where they can sign and say that they refuse to go to the emergency room, and that's still fine. We would also have family members sign that to verify that everyone's on board. And if you're calling someone on the phone, anytime you do a phone order and you get an order from someone over the phone, like a family member or a physician, you want to have another RN or LPN, if there aren't any other RNs, verify that order on the phone, and then both of you sign the order in the chart. It's always important to write down all the different circumstances that are surrounding the fall. And you'll do this often in an incident report. You'll talk about how you found them. You want to be very unbiased, so you'll say, I found resident on the floor in their bathroom, a puddle of water to the left of the resident, appears resident struck head on the toilet seat, those types of things. You don't want to cause any, use any statements that make it sound like it's someone's fault. So you want to just basically say what you saw and objectively state what might be the cause. You can also say what kind of activity the person is at the time of the fall, what staff are present, the type of footwear that they're wearing, any restraints or side rails or alarm use, and then any recent medication changes. The more you document about circumstances like this, the better off it is, because these will hold up in a court situation, and you can help yourself remember what happened if you have a good, thorough documentation. So some of the things you might do after a fall, some different interventions that can help. Besides, we're doing vital signs, right? We're doing things like that. We can also have staff go in, increase the toileting time, have staff go in every 1 to 2 hours to check on them, offer to take them to the toilet when they're in there, see if there's anything else that they need. One of the biggest things that people need these days is their cell phone. Whether it doesn't matter the age, but they need that cell phone beside them, and they'll try to get out of bed in order to go get it if it's across the room. Increased monitoring using sensor devices. Double check blood pressure, double check for orthostatic hypotension. We can do protective clothing as well, helmets, wrist guards, or hip protectors. Make sure that they've got good footwear on. or put a low bed in or a mat on the floor to assist, and then improved lighting. Definitely want to do that fall risk assessment again. Yes, you did it yesterday, but we need to do it again because it helps close this loop of assessment, and it also indicates that you're paying good attention to your resident or patient. Change that care plan to identify high risk areas, and then some focused interventions on exercise and physical activity, medication assessment, environmental modification, and also educate the staff. Orthostatic hypotension, basically, you know what this is. Blood pressure, sitting, standing, lying. And you want to go from check their blood pressure when they're lying, have them sit up, leave that cuff on them. Sit up, take it again right away. Stand up if you need another person in the room to help that person when they're standing. Have that already prepared and take that blood pressure right after they stand up. Sometimes we have to do these at different times of the day, and sometimes our patients need some fluids or some electrolyte supplements in order to help too. Even a banana can do wonders for electrolyte supplements. So those are some things that we can do to assist with that orthostatic hypotension. Now we've talked about environment, screening the home, whether that's in the nursing home, the hospital, or their home, is a big part of fall risk assessment, and we need to make sure that we can identify hazards, evaluate interventions so that we can help that person be safe. So here we go on the right, this cartoon, it's Superman when he's much older, and there he is ready to jump out of the window and probably fall to his near death from the looks of things. So his windows might need to be sealed shut for Mr. Superman. We will stop here and then move on with the third part of our lecture here in just a few minutes.